Hi everyone, today I'm here with Dr. Gressens, a pathologist and blood transfusion, blood banking specialist. He's a chief medical officer at Vitalant, or senior chief medical officer, and he also does global health work as well. So Dr. Gressens, first of all, thank you for agreeing to this interview.
My pleasure. Thank you for having me here today, Adnan, and please call me Chris.
Okay. Chris. And so before we get into kind of like the more of the finer details of what you do, could you briefly describe what pathology involves and what blood transfusion, blood banking
Sure.
involve?
Well, pathology, as you no doubt are aware, is a very large discipline. During my training down at UCLA in the late 80s and early 90s, as I was looking at different areas I might wish to pursue, including possibly biopsy-focused tissue pathology, I found that I missed patients and that the ideal solution was to move into a subspecialty of pathology, as you said, blood banking, transfusion medicine. And the nice thing about that is I get a chance to establish rapport with patients, with physicians, whether they're clinical or laboratorian physicians, with blood donors, and with many others, as well as the general community. So for me, it forms the ideal mix of what I like to do.
What other subspecialties of pathology are there besides blood transfusion, blood banking?
Well, there are many. A few that come to mind immediately are cytopathology. These would be pathologists who delve more into the diagnosis of pap smears and small amounts of cellular material that allow for easier procedures for the patients, and in many cases are just as sensitive and specific as the traditional tissue biopsies. And then there are many other areas such as gastrointestinal pathology, neuropathology, hematopathology, and others. Often the individuals who get into these areas, who explore these disciplines, will practice general pathology as well as have extra emphasis on these other parts of the body, if you will. In my case, I no longer practice tissue pathology at all. I focus exclusively on blood banking and transfusion medicine issues.
What are the most typical cases that maybe a general pathologist would see and that you see in general?
Sure. A general pathologist will see primarily tissue samples from patients who've had different diagnostic and or actual therapeutic procedures, surgical procedures, and will determine where the disorders is, whether malignancy exists, certain types of inflammation, etc., and thereby assist the surgeon, the oncologist, or other in determining what further treatment to perform. My focus in blood banking and transfusion medicine will be on patients with various kinds of blood disorders that can either cause actual disease to them or that can compromise their ability to be transfused. An example of the former is when a patient, for instance, has autoantibodies that react with his or her red blood cells and cause destruction, hemolysis of the red cells. I will work with our laboratory, I'll work with the hematologists and others to determine the type of autoantibody, and that allows for the physician, the clinician, to decide not just how to treat the patient, whether to use corticosteroids, IVIG, rituximab, but also how to transfuse the patient. Then also one more example I'll give that focuses more on just the transfusion side. Periodically we'll see, for instance, patients with, let's say, sickle cell disease who are transfused chronically over long periods of time, sometimes their lifetimes, who will start to develop reactions against certain foreign antigens. And that's particularly prevalent because when you think about it, most people with sickle cell disease are from African American or Mediterranean backgrounds, but most blood donors are primarily still from Caucasian backgrounds. So there'll be slight differences in antigenic profiles that can cause greater likelihood for antibodies to be formed. And And while we do everything we can to prevent this, we do all we can to collect from donors who have similar ethnic and racial backgrounds so as to allow for better responses to transfusions. Still, when patients develop these antibodies, it can become more challenging to transfuse them. And that's just an example of one of the things we do. Very recently, I was working to support a young pregnant woman at a local hospital who had 6 different red cell antibodies, and as a result, trying to find red cells that were compatible for her was about a 1 in 2,000 donor proposition. But we ultimately were able to locally and with the help of other states across the western part of the country find red cells for her, and she did very well.
So what kind of led you to medicine, and particularly the brand of pathology that you practice?
In a nutshell, I knew relatively young that I wanted to help people, that I had some aptitude for science, and that the two converged nicely. Also, I was of a generation that watched the TV series MASH, and that perhaps was a bit of an inspiration as well. When I went into medical school back in the mid to late 1980s, I thought I would be an obstetrician, and quite frankly, I loved the area. I had some great mentors. I did find, though, that after, and it was right about the time I had helped deliver 150th baby, in my experience, obviously for the most part I was there on the side, but at times when things got very busy at a local county hospital, I was it. And I loved each and every experience, but I ultimately decided, well, I'm not sure if this is what I want to do for the rest of my career. And as it so happened, I had some mentors also who were pathologists. I explored the field and decided that was the route I wanted to go, and I've been happy I did that. Now 23 years into my post-residency and fellowship career, and haven't looked back.
So no regrets at all?
No major regrets. A few things I might have done differently, but certainly even with some of my miscues, none of which has been major, but I found that doors have opened that have been unexpected. One in particular was when I had missed out on a particular research grant application I was going for back in the late 1990s, but 6 months later, a friend of mine asked me, an aging hematologist oncologist who had been doing work in a number of resource challenged parts of the world, had asked me if I'd be willing to help him out as he was reaching a point where he no longer could travel as readily. His wife had become ill. So the research door in this case closed, but the opportunity to work with some incredible people for the next almost 20 years of my career has just been extraordinary, and I'm very grateful for that.
It seems like you do a global health work with establishing blood transfusion centers around the world. How do you get involved in that? Was that the main impetus for that? Or?
That was.
Okay.
And we started our first project in the year 2000 in the former Soviet Union country of Georgia. There is what then was a very small pediatric cardiovascular surgery program that was doing wonderful work, but the access they had to safe blood was almost non-existent. And in fact, they had, during the preceding 6 months, had 3 patients who suffered from bacterially contaminated transfusions, and they knew that couldn't continue. That was unacceptable. So this older colleague, wonderful man, Dr. John Watson Williams, suggested that I pitch in, and subsequently made 7 trips, total of about 20 weeks or so, into Tbilisi, Georgia, working with my colleagues there who've done all the hard work. I mean, we're there for consultative purposes. We help prime the pump. We bring some equipment, some supplies, some technological ideas, but then they make them their own and make them better. And subsequent to that, I've had the honor of working in 13 other what sometimes are called developing countries, primarily in Eastern Africa, also in other former Soviet countries, most especially Moldova, little country near Ukraine. And I've seen colleagues and friends over there do wonderful things, and I'm grateful to have had the chance to have jump-started some of what they've done.
How do you make time for things like global health work, or I'm not sure if you do research, or you were actively engaged in research? You did mention that you applied for some kind of research position and you ended up doing global health. That other new opportunity. Do you have protected time to do other things, or?
Yes, and with regard to the research, I'll just freely state that most of the research I do nowadays is focused on case study review series, assisting other colleagues with bigger projects, doing some editorial work for a couple of journals, etc. So I've left most of that to other colleagues, but from the global medicine side, I, for many years, was given relative discretion with regard to my schedule, such that as long as I complied with and met my service hours, and certainly had great relationships with my other colleagues, and so long as I got all the other projects done that were important to the success of what now is Vitalant, I had a number of weeks each year where I could work in other parts of the world, and then on my own time, usually on weekends, evening hours, early morning hours, I did most of the planning work involved in our projects in other parts of the world. So where there's a will, there's a way, and maybe that's one theme I'd like to share with other colleagues who might be watching this is when you find something that's meaningful to you, go for it, number one. And number two, to the extent that's reasonable, while still maintaining a life of value for yourself and your family, do all you can to make it a success. And there's no such thing as meaningless work, especially in our field. I believe that in general, that anybody in the world who cares about what he or she does is bringing value to the world, but especially in medicine. So find what you love, find ways to help others, and do all you can while still appreciating your own life as well.
Could you walk us through a typical day in your life from when you come in to when you leave?
Well, now my typical day involves taking call 1 out of 3 weeks, which is very reasonable. My call as a blood bank transfusion medicine specialist is not like that of, say, an obstetrician who can be certain that he or she is going to be coming in at some point to deliver babies. Most of my call these days is via telephone, via email, via text messages. I certainly am proud to do what I do in support of clinicians who are dealing more often hands-on with their patients, making sure that they have the knowledge and the tools they need to treat their patients. But it's rare that these days that I actually will get called into a hospital at odd hours of the day or night. I'll typically at work focus on about 20% of the time direct patient care issues, many of which are laboratory focused, some of which are focused on what's called therapeutic apheresis, where we do treatments on patients' blood that allow for us to remove and or replace problematic pathologic substances. One example is yesterday we worked with, go back to sickle cell disease, a patient who was experiencing very recently a stroke from sickle cell disease, young patient, 10 years old. And it was clear that she had too much abnormal hemoglobin S in her blood. And so, pure and simple, what's the most effective immediate solution is to remove most of her problematic red cells and replace them with healthy adult hemoglobin-containing red cells. And that's just what we did, replaced about 75% of those defective red cells. and she did quite well. She is now on hydroxyurea, which is a drug known to be very effective for patients like her. For reasons that are complicated, she wasn't treated as effectively as she could have been until very recently, but I am hopeful that the rest of her life will be a much healthier one as a result of, in this case, her having what turned out, thankfully, to have been a very, very mild stroke. These are the kinds of cases we work on as well. Finishing off the answer to your question, about 20% of my time, 25% is spent on administrative and managerial duties, whether working with people who report to me, making sure that they're supported and doing the best work they can, whether making sure processes and protocols and procedures are set up the right way, because that is important. We want to make sure there's some consistency to what we do. Another 20% of my time is spent on blood donor related issues, and I appreciate that as well, because blood donors are among the most generous people I get to work with. So whether making sure that people can donate safely, that the blood they provide to us is safe for the patients we serve, that is another area. A little bit of research and writing, probably 10 to 15% of my time, and then the rest is spent in various other pursuits. About 10% of my time now is spent on international or global medicine. It used to be closer to 35% of the time. At the moment, our priorities are such that while we still value what we do with colleagues in other countries, we also have to make sure that we keep the lights on here at home. So we're finding that balance, and right now it's a balance I like. I hope to do more of the global medicine though in years to come.
How is your lifestyle in your specialty different from maybe other specialties?
Maybe in a nutshell, I'd say that my typical, as I look at my average week, and of course it varies, but I no longer, first 10 years of my career, I easily would work 75, 80 hours a week, partially because I was focused so much on the international and other projects. And I didn't mention teaching. I love the teaching opportunities, whether at California North State University, UC Davis School of Medicine, or hospitals across the region. But I was keeping very busy. I've slowed it down a little bit. I've decided, I'm in my mid-50s now, and my typical work week will be 55, 60 hours, including time spent working on call-related matters. And as a result, I have a little more time with family. I always have loved and devoted as much time as I could to family, and I'm grateful that my now adult children are just super individuals, and to the extent that I might have contributed to that, I'm grateful for that as well. But I'm trying to find that ideal balance, and maybe that's one more thing I'd suggest is that especially in our field, we all have to work especially hard during the earlier parts of our career, and depending upon how hard you want to work from there out, that's for each individual to decide. But I do suggest, and this is based upon my life experiences where I've had a heart attack actually, which helped me to reconfigure some of the focus I have on work versus life. Find what works for you, and enjoy your life is my unsolicited advice.
Was that stress induced?
I think it was. It was a combination, as with so many other things, of my having certain stresses, pushing myself to a point. We can all push ourselves to go without sleep for a night, maybe 2 nights. But I was at times so focused on the task at hand that I pushed myself harder than I should have. And I've learned from that. I still need to do more. I need to work a little bit more on my fitness, a little bit more on my relaxation techniques. But to answer your question, certainly stress was a major player.
So how would you recommend you prevent, or things that you do even to prevent burnout and establish a work-life balance?
Well, that's such an important question, Adnan. And while it'll vary from person to person, I suggest to the extent possible working with the people who mean the most to you to figure out what's that ideal balance. And that may be a spouse, that may be other family members, close friends. Ideally, one's boss, if you will be aligned with that as well. And I've been fortunate that most of my bosses have certainly focused on making sure that I have that balance. But one other area that I think can be very helpful, and for instance, the Sierra Sacramento Valley Medical Society, our local medical society, which is one of the biggest and best in the country, has focused more and more on the importance of physicians and future physicians to be ready to seek support from outside professional sources, counselors, psychologists, others. And I have periodically done that, including after my heart attack, and found that sometimes getting an opinion from somebody who is very objective, doesn't have a bias, can be quite helpful. So there's no weakness to that, no shame to that, just making sure that we are the best we can be for ourselves and others, because if we don't take care of ourselves, there's not much we can do for others.
What are the most challenging aspects of your field?
Boy, this sounds almost mercenary, and I want to put this carefully because so many things I get to do are just so exciting. But one issue, and all of us are going to face it to varying degrees, is that we have to be maximally effective while also being maximally efficient. And by that I mean that we all know that as important as medicine is to our communities, the supply of resources, and quite simply money, is not limitless. And more as competition comes into the fold, as we work for systems and healthcare entities that are requiring that we achieve best results for the least amount of money. We have to figure out ways to make sure that our patients do not suffer from that experience, are not left managed unwisely, while at the same time figuring out how we work through our, and I say this with great respect to our patients, through our caseloads, because we only have so many minutes and so many dollars for each medical situation we encounter, for every patient whom we serve, and we need to make sure we use those minutes and dollars wisely, because the patients' lives depend on this, and our success and our ability to support the patients depends on this. And so I found that to be challenging more and more in my field, and this will be in pretty much every doctor's area as we're seeing mergers and acquisitions of medical entities, whether they're hospitals, whether they're clinics, whether they're insurers. That means that we have greater constraints on what we do, and we'll just have to be more nimble, more creative in how, again, we make sure that the patient is served number one, and not the interest of shareholders or purely of boards, but the patients.
On the flip side, what's the most rewarding aspect of your field?
Most rewarding is when something we do matters to, again, other human beings. And I say that most directly with regard to patients, but it could be with regard to blood donors or with regard to colleagues. From the patient perspective, there was a very recent case where we were supporting the transfusion needs of a little girl who had a very rare autoantibody that was destroying her red cells. And this was following a viral illness that she had. and where we quickly helped to define that antibody, to tell the hematologist what it was so that she could choose the right therapy for this child. 3 days later, the hemolysis had stopped. 2 days after that, she no longer needed any red cell transfusions, and my hope is that she never will again in her lifetime. That feels good. I'll give you one more example. A blood donor recently who came in and had a hemoglobin on our screening assessment of 4.7 grams per deciliter. That's unusual. Most of our donors are very, very healthy and have normal hemoglobins. But when our nurse who had screened him called me, I spoke with this gentleman, very nice man, and he said, yeah, I have been slowly feeling more and more exhausted. I'm dragging. And I couldn't really explain that, but otherwise I felt healthy, so I figured, yeah, why don't I come in and donate blood? Well, in this particular case, he was having a slow gastrointestinal bleed. And again, we don't see this often with our blood donors, but this was a situation where I asked him right away to be seen in an emergency department or urgent care clinic to let his doctor know about this. And by the next day, he had received 5 units of blood and an actual acute ulcer, bleeding ulcer, was diagnosed. Fortunately, he's recovered well, but that felt good, knowing that we could make a difference in his health and knowing that he, I hope, will have a very happy ending to his story. Mm-hmm. Those are the kinds of things that really matter.
Any misconceptions about blood transfusion, blood bank medicine?
Yeah, a few. Some by the general community. Thoughts that blood is tremendously unsafe still persist sometimes. Mm-hmm. And blood is not tremendously unsafe, but it's like any other therapeutic option. There are benefits and there are risks. Mm-hmm. And we very much try to help our clinical colleagues find the balance as to when blood must be transfused and when it's riskier than is reasonable. And more high quality evidence-based metrics have been developed for that very purpose. From the clinician side, though, sometimes they see that carry through too far the other way. Some clinicians who used to transfuse more generously than really was needed now are sometimes so loath to transfuse that on occasion, not often, patients who really should be transfused are denied blood. So again, we're trying to help our colleagues find the right balance. And one example I'll give, by the way, of that latter case, there are, as you may be aware, many indicators suggesting that for most inpatients who are hospitalized who have chronic anemias, one usually should wait until the hemoglobin drops below 7 grams per deciliter before transfusing. Now, of course, that doesn't apply to a seriously bleeding patient for whom all bets are off. You transfuse as needed. But I, on occasion, see clinicians who are so afraid to transfuse that they'll see their patients drop down to hemoglobins that are potentially incompatible with life. Mm-hmm. And so helping them find that sweet spot is one of our goals.
Mm-hmm. Are there certain types of people who have personalities that are better suited for your field, or is it pretty much anyone could?
Yeah, it's a great question, and the answer is that ideally the person who comes into my field is one who has appreciation for both the laboratory aspects and the clinical aspects of medicine. And it's interesting because, as you know, we're all built differently, particularly with regard to our personalities, and some people may be a little bit too analytical who come in our field. Some people may be a little too subjective in their approaches. But I think most people who have enough gifts to become physicians can adjust as needed, with rare exceptions. Mm-hmm. So I guess what I'd say is I would appreciate working with somebody who understands appropriate investigative techniques from a laboratory perspective, understands clinical medicine, and also understands how to work empathetically but also objectively with patients, with clinicians, with blood donors, and with many others, including people in our field who do not have medical backgrounds, helping them understand the importance of what we do. And it again goes back to what all of us will have to do more and more in our careers, is work with accountants and with lawyers and with others at times, helping them understand why what we're doing is important, but at the same time listening to them, because sometimes they have things that they can teach us as well. So maybe to finish answering your question the long way, I'd say maximum flexibility in the way we can look at the world and look at our careers, while without letting go of our principles, finding a way that works best for everybody.
What tips would you give medical students to match into a good pathology residency and a good, maybe like a blood transfusion fellowship?
Sure. As you've implied, one comes before the other. So the pathology is, of course, the specialty, and then during the actual residency in that specialty, one would decide whether or not to go into blood bank and transfusion medicine. So with regard to the former, there are good programs across the country. I would suggest if this is an area that someone wishes to pursue, he or she develop relationships, professional relationships and friendships with people in the field. Ask questions. Understand that some of the best people you might know might be in this or that specialty, pathology, surgery, obstetrics, what have you, and you might have wonderful experiences with these people, but that may or may not predict whether this is the field you want to enter. So looking at both the individuals in the field that is piquing your interest, but also looking very critically at the field itself, so as to be sure that this is truly something you want to enter. And again, for pathology, just like with any other profession, it would go to developing these relationships. Then once one is in a specialty, whether it's family practice, whether it's internal medicine, whether it's any other specialty, deciding where you want to go from there. And I want to make the point, especially to colleagues, and I really do mean this word colleagues, which you are, for California's North State University College of Medicine, that one need not subspecialize to be a tremendously important part of healthcare. Family practice, internal medicine, and other areas in and of themselves are tremendously important. So figuring out just where each of us wants to be in our field is important, and knowing that there are very few wrong paths to take. I guess that would be my recommendation, keeping that in mind.
Moving on to more of kind of the business side of things, what employment types or settings are there? Is it mostly bigger groups, or are they like independent contractors, locum tenens work?
Yeah, in my field, in pathology, and then I'll talk about transfusion medicine in a moment, primarily pathologists work within group practices, at least in the state of California. Some of these are connected with healthcare entities such as Kaiser affiliated group practices, Dignity Health affiliated group practices, etc. There are certainly locum tenens opportunities, and I'm not terribly familiar with them, but I certainly know of some colleagues who do enjoy working in different geographical areas periodically for relatively short periods of time. As far as, and this is something to keep in mind in general regarding subspecialties, one needs to remember that the more specialized we become, if we choose to go this route, the fewer geographic options will exist. Case in point, blood banking and transfusion medicine. There are fewer than 1,000 people across the country who work in my field, and my opportunities have been super throughout my career. But if I wanted to work somewhere else, and I don't, I would be limited primarily to larger metropolitan areas, and that's the case for certain other specialties as well, such as hematopoietic transplant, traditionally called marrow transplant medicine. You don't do that work outside of fairly large cities. There are only a few such transplanters in the community of Sacramento, relatively larger number in San Francisco, and so on. Whereas people who work in more general areas, family medicine being one of them, family practice, the sky's the limit as far as areas to work and opportunities to have.
So how well are pathologists and blood transfusion specialists compensated generally?
Great question. It depends. So for those who work in group practices, my understanding, without going into exact dollars and cents, is that the remuneration is pretty good, probably at the top of the heap, if you will, of pathologists. For those who work in more academic settings, the upfront remuneration is relatively lower, although there are, of course, other benefits, such as being in an active, engaged academic environment, having a chance potentially to do research, and also some of the benefits, including retirement plans, are quite good, and healthcare. In my field, probably middle ground, I would say. I certainly have been afforded the opportunity to raise my family well, to live in a nice home, to do a few things that as a child, and I had wonderful parents and family, but our means were somewhat limited, so I've done more than I could do as a child for my children, and that's kind of ideally the way life should be for anybody, that we all want to do a little bit better for our children than our parents were able to do for us. So my career has afforded me that opportunity. When I eventually decide to retire, and I may not fully retire, I'd like to keep a little hand in this, especially the global medicine side, I will be able to do so reasonably comfortably if all goes as planned. So I guess what I'd say is, from the career and the perspective, the income and security perspective, there are very few disciplines in medicine where we won't be given pretty good opportunities in this regard. In my field, certainly that's been the case.
Where does it rank kind of in relation to other specialties?
My understanding is that it is in the mid to perhaps even lower upper quartile. Now, by example, or by contrast, I might say, in contrast, typically a surgeon, those who are doing procedures, especially some of the more complex procedures, typically are rewarded at the greatest levels. Not fairly so, but those who are doing medicine, pediatrics, in some cases family practice, are not going to be rewarded financially as highly, although still usually the paychecks are nothing to sneeze at. And pathology, again, is somewhere in between, and again, I'm fairly compensated.
And what tips would you give new doctors on managing their finances well, maybe like investing in things like that, or even if maybe they go pathology to maximize their income in those?
Number one, planning for the future, and this applies to anybody in any field, but I do share this a lot with some of my junior colleagues. It's so easy when one has greater disposable income to want to go out and buy a few shiny objects, and that's human nature. And I did a little bit of that myself, and to some extent I regretted it when I paid back the debts, but I did pay them back. Having a rainy day fund, of course, is so very important. And also getting into retirement planning as quickly as possible. Most of us will have access through our careers to strong retirement possibilities, whether through 403Bs, 401Ks, or occasionally through traditional pension retirements, such as the academic physicians, such as the UC system still have. But I guess what I'd really strongly suggest is save as much as you can. Work with somebody you trust. I do recommend finding a good financial advisor who is going to be working with you, with us, in such a way that he or she is not biased by opportunities to make money by selling this or that stock or mutual fund or insurance product. Rather, working with somebody who is fee for service and who is going to help guide you in making the best investments you possibly can. Now, the last thing I'd say is not myself being an expert, but having spent a few hundred hours researching over the years what makes the most sense for me and my family, making sure that you really do understand the high points of being well diversified, of making sure to contribute, especially early in your career, as much as you comfortably and possibly can, and maybe even a little uncomfortably can, to that future retirement. In our field, in most cases, we'll have the opportunity to practice for a very long time. Even surgeons I know who ultimately have lost the ability to trust fully their hands, as tremors or others the problems have developed, still have their minds and can do a lot of other important things that allow them to prolong their careers. So many of us will have the opportunity to work almost as long as we want. But wouldn't it be nice also to have the opportunity, if we make smart choices, to be able to turn it off whenever we want as well, and say, it's been a good career, but now I'm on to the next chapter. So I do highly advise thinking about something, as somebody in their late 20s or early 30s starting their career, might not think about what comes ahead. Well, I'm 54 now, so I'm getting a little closer, and I sometimes wish I had done a little bit more.
How do you recommend staying on top of all the advances in medicine, or what are things that you do?
Yeah, what I do is a lot of reading, whether through Up to Date, whether through all the professional societies of which I'm a member, and the journals that come out. I certainly recommend, even if you read your own disciplines literature, that you keep in touch with New England Journal of Medicine and JAMA, the Journal of the American Medical Association, that you keep an eye on what's going on in the newspaper, because occasionally I'll be apprised of something important to my field first by what I happen to read in the Sacramento Bee or the New York Times or the Wall Street Journal, and then I'll go and investigate further in the peer-reviewed literature. I do suggest that whether on a case-by-case basis, as issues come up and you need to learn more about this or that clinical entity, or in a general basis where you're reviewing large topics and making sure that you're prepared when the cases come up, that you and all of us work this into our daily lives. And I'll close by saying that overall, between what I do for patient consultation work, for preparation for this or that possibility that may come across my desk, or for some of the writing I do, I spend about 8 to 10 hours a week reading and reviewing to make sure that I'm on my toes.
What kind of advances or changes in medicine do you see in the next few decades?
Well, so many, of course. One that I think is going to apply to all of us, and then I'll mention a few that apply more to my field. The integration of some of the very sophisticated computer algorithms that are going to support us in understanding how best to manage our patients' individual needs. And of course, I'm talking artificial intelligence. It's not going to replace us, but it's going to complement us. I'm certain of that. And isn't it going to be an exciting career boost when we can enter findings for patient A, B, or C into the computer, or the computer in an appropriate way can actually access information on our patient and actually give us ideas of what might be going on. Again, it should never supersede us, but if the computer can figure out for us, there's a 70% possibility that diagnoses XYZ are in play, and then we can examine further and make up our minds for ourselves, well, that's better medicine and better efficiency. For my field, a couple of things I'm really looking forward to are better means for pathogen reduction within blood components to eliminate the risks of viral and parasitic and bacterial disease transmission through blood. And then ultimately, probably what will be the final stage in my field will be when we can actually grow blood products right on the shelf using cellular therapy-based means, matrices of precursor cells, progenitor cells that can grow red cells or platelets, white cells or other. And I'm very excited by that. And obviously some of that, to a limited extent, is already happening with regard to some of the recombinant coagulation factors that are being developed, such as recombinant factor 7, 8, or 9, which have been real lifesavers for many patients, including those with hemophilia. But we're going to be taking it to the next level over the next 20 years. Much of this is going to occur after I retire, but I'm looking forward to that stage.
Okay, so last question. What tips would you recommend for medical students to become good doctors?
Passion, commitment, a willingness to push ourselves where needed to that next level that might at times surprise us as far as our ability to recognize what the patient is going through and what is the best set of options for management of the patient's condition. The application of humor, where appropriate, I think can be a wonderful gift, not just to the patient but to oneself. Being certain not to take myself too seriously, I found has been not just important in making sure my ego doesn't inflate out of bounds, but also to just keeping me more level and capable. In a nutshell, caring about that patient in the same way we would care about the individuals we love the very most. There's nothing most of us wouldn't do, nothing legal or ethical most of us wouldn't do to take care of our parents, our spouses, our children, to the ultimate of our ability. And I think applying that same principle to our patients is absolutely critical. At the same time, though, knowing that that eventually we do need to have a separation that allows them to live their lives and us to live ours. Mm-hmm. So it's a balancing act. Sometimes these motives, these mechanisms seem to be at conflict with one another, but I don't think they really are if we can understand what's most important to our field, which is professionalism and compassion.
Okay, with that great advice, that concludes the interview. Thank you guys for watching. Thank you, Dr. Chris, again, for being part of this interview. If you have any questions, you can leave it down below in the comment section, and I'll ask Dr. Chris, and we'll get back to you. Thank you guys again for watching, and have a great rest of your day.